So thank you, Selena. Thank you to Ruben and Mort for the invite. It's a great pleasure. It's a great meeting. Do a wonderful job. In the interest of time, I'm going to whiz on and try and discuss with you advances in sequencing. I think these are the models that have been built of myeloma in recent times, and you can see that over sort of evolutionary time on the bottom axis and tumor bulk on the vertical axis, you can see that the bulk of the tumor increases. It increases through the stages of MUGUS, smoldering myeloma, myeloma, to then these more aggressive clinical states later in the disease, such as high-risk myeloma, extramedullary myeloma. And on the bottom, you can see some of the genetic features that define myeloma and what pushes the cells through this process. But entirely relevant to the introduction we've just heard, you have to consider the co-evolution of the clone in the context of its microenvironment and what it does to tumor-promoting and tumor-suppressing cells in the microenvironment. I'm going to focus predominantly on the tumor cells themselves and talk about where we are today, which is the top panel in terms of a rudimentary knowledge of the genetics of myeloma, to where we want to be in the future, where we use next generation sequencing approaches to define clinical features of the disease that actually have meaning in the clinic. And again, relevant to this session, the current status is that we should think of it as monolithic myeloma, where we treat everybody more or less the same with induction, consolidation, and maintenance. But maybe the future should involve defining risk strata and biological strata of the disease, where you try and match the treatment to either the biology or the risk. That's some way on in doing this. There are biological factors now that work in subsets, such as venetoclax in the 11-14s. There is a history, I think, of doing risk-stratified studies, and these are the risk-stratified studies that have been done to date, but I think we need to get back into utilizing this information in the clinic. And so, following on from Big Ben, what is it that we're really trying to do? And I hear from out there that the myeloma genome is incredibly complex, it's difficult to understand with 30,000 variables. How are you ever going to get information? Well, it's this bus analogy. So you see that the whole bus is probably genetically complex. That's the big red circle, but none of those people in this case, or mutations in the case of cancer, are doing anything at all to the disease process. And analogous to the bus driver, there are very limited variants which are actually pushing the disease forward. And if you can understand those limited factors, they will provide good ways of biologically stratifying the disease, risk stratifying, and could provide novel targets for therapy. So if we talk about risk stratification to start with, this is a graph of possibly 60 drivers, or certainly 60 molecular events, and they're lined up in their frequency, and on the vertical axis is the ISS stage. And so you can see there's almost no correlation between genetic factors and the ISS, arguing that the genetic factors are independent of the ISS and could add important information. And so with Nikhil and Anjan Thakurta from Celgene and in our lab, we've put together this myeloma genome project data set of 1,300 approximately newly diagnosed patients, all of which have next-gen sequencing, exome data, clinical data, which allows us to ask specific questions related to that hypothesis. And so here are the mutational drivers that we have found up to now. And in the figure on the left, these are the frequency of the variants, and you can see there's only a limited number of high-frequency variants that become at low level very quickly. If you ask, are there different variants in each different etiologic subclass, the answer to that is yes. And the different molecular subgroups are laid out at the bottom and illustrate that, and the genes that are involved are described. The other way that you can find oncogenes and tumor suppressor genes is not looking if they're mutated more frequently than other genes, but if they are mutated, does the pattern consistent with them being activating, in which case they're oncogenes, or inactivating and tumor suppressor genes. And so again, this is a list of tumor suppressor genes and oncogenes. The oncogenes in red, tumor suppressor genes in blue, and there seems to be important genes there, some similarities to other hematologic neoplasia. Myeloma is clearly a disease of the RAS pathway, but we do find RNA splice variants, epigenetic variants as well. And that's incorporated or encapsulated in this word cloud, where the frequent genes are in the largest text. And you can see that NF-kappa B and RAS are really important. And genes like DIS3 and FAM46C, we still really don't understand fully their biological role, but are important. The problem with this data and personalizing therapy and mutational directed therapy is shown in the bottom of this figure, which is the cancer clonal fraction for each of these variants, which is, while in some close to 100%, in the majority of cases can be in the order of 50% or even less. So if you target such a gene, then you'll only target 50% of the tumor cells. And this pattern is very similar to what you'd expect in biological systems, such as the ones described by Darwin, where the tumor develops by branching evolutionary pathways rather than in straightforward linear progression. And so the models that we've used over the years with this direct pathway are probably incorrect. And now we have this situation where even at the earliest stages of the disease, there's branching and diversification of the tumor cells, and then a single stem cell changes its behavior, crosses a threshold, and starts to behave like the next step in the process. And by a process of clonal sweeps, comes to replace the majority of cells in the bone marrow. And this really is important for therapy, because if you target these early variants here, all of these cells are killed, whereas in these branching pathways, if you only target one of the red stars in the small pathway at the bottom, then you simply prune the tree rather than killing the tumor. And this is important, and we need to understand this process more as we go to more mutational targeted treatment. And the other fact that we haven't taken into account is oncogene dependencies. And this slide tries to illustrate that point, that there is clearly more than one mutation that drives the gene. They interact together and interact in a specific way. So if mutation 1 collaborates with mutation 3, as in the bottom here, that pathway will be selected. This should be redundant and never occur if it does nothing to the biology. And if it's just random with mutation 2, then that just generates a passenger variant. And so there are distinct oncogene dependencies in myeloma that you can see with such a large data set as this. And let's try to sum it up in the bottom of this figure with the RAS variants and the position of mutations within RAS. So each subtype has a specific spectrum, nature of RAS mutation, arguing that you need to understand more to effectively use mutational targeted treatment, even against RAS. I've spoken about mutational variants, but there are also copy number variants, and the sequencing data allows you to map the genome from one end to the other in a genome-wide, unbiased fashion, and to define recurrent loci of copy number gain or loss. It's the majority of time it's copy number loss, and there are 39 recurrent copy number variants that occur frequently, and at those loci you may imagine there are drivers of disease. So if you take those 39 variants, put them into a Kmeans cluster analysis, the disease clusters into these clusters as shown here. There's an awful lot of information in this, but there are two broad hyperdiploid groups and then a number of non-hyperdiploid groups with these recurrent copy number variants on 1p, 14, 16, and we'll come back to that. The importance is each of those groups has prognostic importance and seems to be relevant to disease progression. So you can use this information to build on classifiers that we've had previously and introduce these copy number groups here into the background of this TC classification, because these variants help define prognosis. A random fact now is that the extent of copy number change seems to be important prognostically. So in the BRCA-related cancers, this has been important. So the extent of LOH has been used as an indicator for treatment with PARP inhibitors. And something very similar happens in myeloma. If you have more than 4.6% of LOH, you can see that the frequency of that increases by disease stage and also seems to have prognostic value. So the extent of LOH is a novel independent prognostic factor. Coming back to the hypothesis about drivers and how many of them are there, the more you have in the cell, the worse the prognosis. However, there's a group of 20% of cases where we can't find any mutational drivers or any copy number drivers, arguing that we're still missing significant mechanisms that are important in pushing myeloma forward. So in the last set of slides, I want to come to how do we use this information to define risk strata. And so we took all of these drivers and asked, are they prognostic, and how much of the prognosis do they describe? And so in the top you have PFS and the bottom OS, and you can see that this is the hazard ratios of the contribution of the variables to PFS and OS. And you can see that they contribute significantly in the order of about 30% to PFS and 40% to OS. But still, there's a lot of information that comes from clinical factors and age. So I'm going to really whiz through these. So this is 1Q. So gain of 1Q alone is not a really significant prognostic factor. If you have more than 4 copies, you have a dire PFS and OS. So AMP1Q is really important. Bi-allelic inactivation of P53, if you have that information, loss of 17p no longer becomes an important clinical factor, arguing that we should replace all of that 17p minus with information from sequencing on the status of the 2 alleles. 414 collaborates in a statistically significant way with P53 deletions, and if you have 414 and biallelic P53 inactivation, you do very badly. And there are interesting dependencies. So on 1P, the 3 genes on 1P interact with 1Q in a very peculiar fashion, and this is with FAM46C. But if you have amplification of 1Q Q and FAN46, so you have a very poor outcome. You have to put all of these factors because they co-segregate into multivariate analyses. And when you put them into multivariate analyses, the number of variables shrinks really very rapidly until you only have a limited number of truly important factors that drive risk. And again, these are shown in this feature. It comes down to 414, amplification of 1Q, and bi-allelic P53 inactivation. And so you can take those factors and then say, in recursive partitioning analysis, can you define clinical prognosis? And you can see that simply with the genetic factors, you can come up with something that looks very rational and functional just based on the three factors I've discussed. And you can integrate clinical factors into this, which is very important, and you come up with very complex looking nodal structures where each node is described in panel B and their contribution and what they are in the left panel. This condenses down nicely into what would look like a revised ISS, where you have low risk, high, intermediate, and high risk, as shown in this figure, that validate in test sets really rather nicely with high specificity and sensitivity. So you can gain more information than you would have with the ISS. I'm going to skip that one. But maybe that's not what we want to do. I think we're in a time where drug development is becoming very difficult in the field of myeloma. And if you could define a very high-risk group that had a prognosis similar to relapse refractory disease, you may be able to skip that escalating or forward movement of drug development and go straight for newly diagnosed patients. So it could be that if you defined a group that was very resistant to therapy, that would be ideal for CAR T therapy, say. And so in this slide, you can see that there's a 5.7% group defined by nodes 7, 11, showing what's in that group that really is an ultra high-risk group. And in a meeting on lymphoma myeloma, I think the analogies with two-hit lymphomas is very, very sound. I think it represents something that looks like a very similar group. And I'm going to finish there, suggest to you that we are making progress with the clinical use of genetic factors to risk stratify. I think there is an ultra high risk group that you can define based on amplification of CKS1B and bi-allelic P53 inactivation, and it's a good site for drug development. And the slide is one of the speakers from later in the day and is escaped from Scotland and what they get up to in their spare time. So thank you very much for listening.